Sir, we are live now. With all your permission, I'm starting this webinar for today.
Yeah.
Afternoon, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. Let's welcome today's speaker with great honor, none other than Dr. A.P. Kochar, sir. And let me share some of the achievement of sir. Sir has done MBBS, MD in Pediatrics, MAMS, MRCPCH, FIA, MSA, and Senior Consultant at Pediatric and Adolescent Endocrinologist at Indraprastha Apollo Hospital in Savita, Bihar, Delhi. And today, sir is going to discuss on a topic childhood and adolescent obesity, the bombshell. To know more about this topic, I would like to invite sir and sir. Over to you, sir. Kindly proceed from here.
Yeah, okay. Thank you, Faraz, for a nice introduction. So today I'm talking about a topic, which everybody wants to know what should be done, what is going on, what's happening, and where, where we ending. So basically, obesity is becoming an epidemic, and everybody is concerned about what's happening. So I'll tell you in try in a nutshell, like a bird's eye view of what the things are. So So first of all, this is we start as a case, a 3-year-old female child who came to Polo Hospital. Second day, consenting on marriage parents came with complaint of increase in appetite and weight gain for the last 1 year. So there was a history of increased interrupted eating since since 1 or 2 years. She's just 3 years old, right? So the last 1 year, they noticed that she is too much eating. So she had a history of recurrent infection were present, history of snoring, daytime sleep. Obesity, hypertension, dyslipidemia, no history any developmental delay, no history any drug intake. So this was all was there, and this was there as part of the history and everything. So taking that into consideration, the child was very obese. Child will coming out of the further data. The birth history was normal, full term 2.7 kg, cried after 10 minutes of delivery, and admitted in hospital for 2 days because of hypoxia. Okay, so birth is a full-term 2.7 kg, cried after 10 minutes of delivery. Admitted also for 2 days because of hypoxia. No breastfeeding formula was given, so no breastfeeding formula was given. Dietary history, voracious appetite. 10 to 2 chapatis per day, 5 fruits per day, very, very lot of food. So she was always, when she entered the OPD, she was always wanted to eat. They had kept 2 balls of fruits and 1 ball of, some other things like, I don't exactly remember. So they just take it out, give it to her, just take it out, give it to her, and then she will take it, eat it. So dietary, this was a voracious appetite. Imagine she's just 3 years, weight 38 kgs. Height 99. So weight, she was like a 10-year-old child. Height was like a 4-year-old child. So clinical examination, the vitals were, heart rate was normal, under 13, respiratory was 36 per minute. The BP was slightly on the high side, 120, 80 for a 3-year-old child. It's a lot. And SpO2 was 80%, 2% on room air. So it became 100% on just by giving 1 liter of oxygen by mass. That's what they actually, they had a, they had an oxygen cylinder along with them when they came. So they knew that's happening to the child. So this patient was not from in India, it come from Bangladesh, and they come just for this, that there's some problem in this child. So examining from head to toe, these were dysmorphic features were there. There's a buffalo hump. So there was a big pad of fat on the back of the neck. That was the buffalo hump was there. Striae were present all over the abdomen, all over the body. Acanthus nigrans was there. The other nigrans is basically pigmentation of the skin, which is occurring. So you can see in the back of the neck, you can see in the armpit, you can see between the thighs there. Tanner staging was that. That means SMR. SMR was B1, B3. So she was basically pre-pubertal. So there was no breast, there was no oxygen, no puke and all. Lab investigations. Were the lipid profile was triglycerides were 86, VLD was 5, cholesterol 159, HDL 35, LDL 119. The cortisol 8 p.m. was 14, 8 a.m. was 1.39. So the cortisol fine. The glucose severance, they had done an OGT and they had insulin levels. The OGTs were 1 hour 202, plasma glucose after 2 hours 144, insulin after 1 hour 440, insulin after 2 hours 436. So you can see very high insulin levels, very sugar was like a diabetic. So LFT was normal, calcium 9.8, vitamin D3 was very low, 16. LHFS is normal, that means a pivotal hormone was like a pre-pivotal girl. Estradiol was 29.9, slightly on the higher little. ACTH plasma normal, ACTH normal, karyotype was 46, a girl. Okay, no other abnormality was it, so it was typical of a normal. Whole exome sequencing was done, report was waited, we got a report recently, it is Prader-Willi syndrome. So we got it done from two places. The first one came, no pathogenic variation seen, nothing was there. So the second one, we got it done from another gene lab, and they reported Prader-Willi syndrome. So basically, that's why the labs also make a difference where you get the genetics that makes a difference. So therefore, this girl finally turned out to be a Prader-Willi syndrome who was eating oral appetite, eating a lot. There may be difficult, presentation and the variation may be there in presentation and Prader-Willi syndrome, but we'll talk about it more in the next slide. So the objective of today is to define obesity and overweight, conduct a diagnosis approach, assess comorbidities of obesity, patient-centered approach. So it should be like that. And what are the preventive strategies which are there? So obesity is defined a condition of abnormal excess fat accumulation adipose tissue to the extent that health may be impaired, so which may result in long-term morbidity and mortality. So basically the dysfunctional body fat. So it's a basic now it's a global epidemic. Child obesity is basically a chronic disease. It is not just a lifestyle disorder, it's a chronic disease. We'll talk more about it in the next slides. So we Indians as ethnic group have a high risk for insulin resistance, syndrome X, and which is, and central. So we are risk for, insulin resistance and central obesity. So which are both forerunners of diabetes and coronary artery disease. So these are two, finally morbid condition or mortality can also. So basically now this is changing. Nobody wants to use the word terminology. Obviously, they're saying use A, B, C, D. So A, B, C, D mean adiposity-based chronic disease. So it's a chronic disease. It is not a disease just of lifestyle or just, your disorder and then that's why you get it because no information. No, it's a basic chronic disease. So which is a term used by American Institute of Clinical Endocrinology to describe obesity. So they say obesity is adiposity-based chronic disease. So it's a more accurate term than obesity to be used because it contains full range of the disease. It includes adiposity, that means excess of fat, and its complications. So the ABCD conceptual framework work includes several factors that contribute to obesity. Biological factors, genetic hormones, healthy, unhealthy lifestyle, sedentary lifestyle, lack of sleep, stress, underlying medical condition, or if patient is taking medications and other condition, social economic factors, the culture, ethnicity, the beliefs, the policy and inequalities. So all this is making a difference. Now, India's obesity epidemic. So that the Pediatric Endocrine Society, they say that yes, it's a disease, but they have not come to the definition of ABCD. They still say obesity. But they are trying to say, they are also saying that it's a chronic disease. So you have to have prevention, you have to have measure of prevention, you have to measure of diagnosis, you have to have measures of how to, control it and the treatment part. So India's obesity epidemic is a very. So this is a Pohan March in 2021. It was obesity in India's concern. So by 2030, we expect that 27.8 of the overweight in the world would be Indians. So this is quite a big figure. So India's epidemic, they're saying that in 10 years, obesity in India has more than doubled in the last 10 years. Number of obese people in India have gone up to 30 million, maybe more than that also now. And obesity is increasing risk of developing diabetes. So if you're obese, more chance of getting diabetes, around 80 to 85%. And 30% of the urban children suffer from obesity. So 30% of the children, of urban children, they suffer from obesity. So that's another thing. So basically, there was a comprehensive national nutritional survey was done, and it was found that overweight and obesity is 1.6, 0 to 4 years, to 4.8%, 10 to 19 years. Okay, so that's something interesting that it is increasing. And then they came that with a figure that 14.9 million obese children in 2017. So now it's 2024. You can imagine how much must have increased, which was the second highest rate of child obesity in the world. So maybe India may be going to first. Now it is the second highest rate in the world. So we have evolved a lot over time. And we are now, if you see, we started like these primates and then grown up, started walking, then using the spear to find our food, hunting. And then finally, we go a little more better, higher tower, and finally landed up with obesity, with drinking Pepsi, Coca-Cola, and all those things. So this is what we have done. So this is why it's a number one health problem in the 21st century. And basically, obesity is that is obesity. So number health problem present in the 21st century. So do we need to treat pediatric and adolescent obesity? That's a question. So just to give an example, this is a male who came, was seen at 11 years of age for obesity. And he was advised lifestyle modification, that you do lifestyle modification is no problem. It's just a lifestyle disease and you will become fine over it. So he went away. He was lost to follow up because nothing was done except for khana kam khao, exercise karo, don't eat too much of paneer, don't eat too much of junk food. So then he was lost to follow up. He came back later at 15 years. So after 4 years with type 2 diabetes. So you need to treat pediatric obesity. You cannot just say khana kam khao and there's weight kam karo. That's all. So this is just a reference. That's why it was old, long back. So this was basically he had come BMI was shifted to 25. His weight increased in height also. The BMI is around 25.5. His HbA shot up from 4.7 to 9.8. So you can just imagine fasting sugar is 92, it went up to 90. So basically, there was a great change in the, this one, and then he landed up with type 2 diabetes. So first we go further, we need to talk about the definition. The definition by CDC, and what does the IAP say? The IAP is Indian Academy of Pediatrics. They have their own this thing. So what do they say? So what do they say and all? So what is the basically? So basically, CDC is underweight is less than 5th percentile. Normal weight is 5th to 85th percentile. Overweight is defined as BMI above 85th percentile and below the 95th percentile for children and teens of the same age group. Okay. So BMI above the 85th percentile, overweight, and below 95th percentile for children of the same age. Obesity is BMI above 95th percentile for children and teens. So your overweight is between 85th to 90th percentile and obesity is above 90th percentile. Now what does IAP say? IAP, they brought out charts at 25 for obesity. So they define overweight and obesity in children from 5 to 18 years. Below 5, use WHO growth charts. After 5, use the IAP. 5 to 18 years of age, adult equivalent of according to International Obesity Task Force, adult equivalent 23 and 27 cutoff lines. That means centiles of that cutoff as present in BMI charts are used. So the 27 adult equivalent is equal to 85th centile is overweight. The 27th adult equivalent is 95th centile is obese. So you have this with you. So 27th adult equivalent 85th centile is overweight. 27th adult equivalent 95th centile is obese. Okay. So this is what you have to, make it and understand that this is a word. So we will be talking only from the IAP point of view. So Indian children who are less than 5 years, what do you do then? So if your child is less than 2 years, it is length. If it is more than 2 to 5 years, it is height. So Indian children less than 5 years, weight for length, weight for height, using WHO chart should be used to diagnose overweight and obesity. A child whose weight for length or weight for height is greater than 2 standard deviation or more than 97 centile, but less than 3 standard deviation, less than. So lying between 97 to 99 percentile is overweight. So if it is more than 99.9 centile, it is obesity. This is WHO growth chart. Children below 5 years, weight for and weight for height should be plotted every 6 monthly after the first birthday to see what is happening to the child. Okay. Now there is something called as weight circle. That is also being used. Weight circle for height is also being used now in many places. So weight circle is more than 17th percentile cutoff. Is used to recognize children with central obesity and risk of developing metabolic syndrome. So there are now weights, weight circumference. There are the charts are there where we can see from the weight circle whether the child is having central obesity. So there are also classes of obesity. There is class 1 obesity, then there's class 2 obesity, then there's class 3 obesity. So let's talk. Class 1 is when, between your which is there between the IAP growth charts, which is which is at the, that we had already discussed this, that at the 23rd or 27th. So between the 23rd, 27th adult equivalent, class equivalent. So with up to 120% of the that is called as class 1. Class 2 is severe obesity, 120% of the IB cutoff value of 27 adult equivalent. Class 3 is 140%, that means above 140%. So that is class. So 120 to 140 is class 2, above 140 is above obesity value of cutoff of 27 adult equivalent, that's class 3. So class 1, class 2. These are also, there's some classes of the type of severe obesity. So you can see here very nicely here this BMI charts, IAP5 chart from 5 to 18 years, then BMI charts for girls from 5 to 18 years. So 23rd adult equivalent, this is the risk of overweight, 27 adult risk for obesity. If you this is it. So this is basically how you're getting this charts, and this is how you're getting the overweight. So this is the CDC growth charts, and here you have 85 percentile, you have 95% for boys. So here something lying here will be overweight, above 95 percentile will be obese. So here you have again, you have here, for girls, the same thing. So blue color is for boys and green color is for girls. So there's an extended international obesity task of body mass index cutoff for thinness, for overweight and obesity. So the international cutoff are available corresponding to BMI cutoffs of at 18 years. So 16 BMI is thinness is grade 3, 17 BMI is thinness grade 2, 18.5 thinness grade 1. 23 BMI, overweight, Asian cutoff. So overweight for Asian cutoff, 25 overweight, 27 obesity, unofficial Asian cutoff. So 30 obesity and 35 morbid obesity. So that's how you have the body mass index cutoff for thinness and for this thing. Okay, so that is how you're going to, listen. Overweight, 25th. So that's how the intervention race was. So they took 23rd as anything between 27 as overweight and anything above 27 as obese. Now we have come to the definition. Now let's talk the causes of, what are the causes of etiology of obesity. So the etiology of obesity is simple or is pathological. Simple means, nutritional obesity. So खाता है, eating खा रहा मोटा मोटा हो जा रहा है, and that's it. Pathological, there's some cause. The most of the cases we find are nutritional, simple obesity. Very fond of eating, very fond. I think Indian kids are most of the kids are very fond of eating their food. They like to eat junk food. They like to eat pizza. They like to eat burger. They like to eat paneer. They like to eat, everything from outside. So simple that. Pathological is some maybe endocrine disorder, maybe a brain damage, maybe genetic syndrome, maybe monogenic disorder. So endocrine disorder, glucocorticoid excess. So too much of glucocorticoid excess, and then hyperthyroid and growth hormone deficiency. So you have this. So endocrine disorder, glucose excess, hyperthyroidism, and growth hormone deficiency. So you have this endocrine disorder. So therefore, glucose excess means you maybe have Cushing syndrome, hyperthyroidism, and growth. So we'll show you some few slides about endocrine cases, because being an endocrinologist, I show the brain damage. If something happened to brain, so if everything happened to hypothalamus, there is a satiety center in the hypothalamus, there is some centers in the hypothalamus. So if they are damaged, you feel hungry. So hypothalamic tumor, hypothalamic trauma, a surgery which causes damage to the hypothalamus. Genetic syndrome, Prader-Willi syndrome, Cohen syndrome, Bardet-Biedl syndrome, monogenic disorders, leptin deficiency, leptin receptor deficiency, maybe promomelanocortin deficiency, MC4 receptor deficiency. So there may be there that cause monogenic disorders. So how do you approach for pediatric and adolescent obesity? First, rule out endocrine and genetic causes. So endocrine, the patient will be short and poor growth velocity. That means definitely I'm going for a endocrine cause. Second will be genetic. Genetic may be mostly syndromic. So they'll be having some syndromic features and maybe dysmorphic features will be there. Developmental delay, visual defect, hearing defect, or hypogonadism or undescended testes in boys. Then you come to monogenic. Monogenic is severe onset. In the first 6 months, 1 year of life, you got very, very fast increasing obesity. Like this girl, we were confused that it's monogenic, but finally it came out by the genetic testing, it is Prader-Willi. So severe early onset dysphagia, normal intelligence, okay? No developmental delay. So there's development delay in case of genetic. And hyperphagia, eating a lot, that's there in that also, and hypogonadism. So the main thing here is normal intelligence and no developmental delay. So monogenic obesity, so here you have the adipose tissue from where leptin is released. Leptin will go and act on leptin receptor. Leptin receptor will go and act on promomelanocortin Here, as you can see here, so in the hypothalamus, there are two nuclei, the arcuate nucleus and the paraventricular. These are very important for as far as your satiety is concerned, your eating is concerned. So in the arcade nucleus, you have this leptin receptor goes act on promelanocortin. The promelanocortin will release PC1, PC1 prokinase, and that will go and release MSH. So MSH is a melanocytin hormone, and that will act on the receptor, MC4, MC receptors, and which we have the same. So you will have a satiety decrease. So you will take less food intake and increase metabolic. So you will ultimately stop eating. So that is what they are. So here what is happening is now in these patients of monogenic obesity, there may be leptin deficiency. So leptin is not getting there. So when leptin deficiency is there, so they will early onset obesity, hyperphagia, hypogonadism, and normal time. So they may if leptin is okay, but there is the problem leptin receptor deficiency that we call again same early onset disease, hyperphagia, normal telomeres, hypogonadism. Then comes same, it is same. Most of these patients will have same. So then comes POMC deficiency, promomelanocortin deficiency in the arcuate nucleus that will cause adrenal crisis. So here, there is something in that same receptor there in adrenal, so we'll call adrenal crisis. It will cause red hair. It will cause really onset. So these are something different. Then you're up maybe at the receptor MC4, melanocortin 4 receptor deficiencies there. Here also again, severe early onset obesity, hyperinsulinemia. Okay, that's very important. But the important thing here, there is no developmental delay at all and the normal intelligence. So that's why hyperinsulinemia, if you have if you MCA deficiency and POMC, red hair. Red hair, that's another fine, adrenal crisis. So that's how you, different monism. The important point to remember that if parents should know that if the patient has severe weight gain from early infancy and has risen above 90th percentile of weight by 3 years of age, he should be informed availability of genetic testing for monogenic obesity. Okay. Why? Because there are some drugs available now, which we will talk later. Familial factors for obesity. So the familial factor is both parents are lean. 9% is for child obesity. If both are lean, 9%. If one of the parent is obese, 40%. If both parents are obese, 6 to 8%. So when you treat a child for obesity, you have to treat the parents also. See where the parents are. If they're obese, then you have to tell them this. Otherwise, nobody will follow the proper the instruction will not be given. So that's why it's important. That's why familial factors. So let's take a case, a boy at 23 years, 12.3 years old, height 160 centimeters, weight 60 kgs, target height 170 centimeters. What is the height age and what is the weight age? So this is, I think I have discussed one case before. I've talked in this, I've given before a talk on this growth charting. So basically, what you have to do, your height age is you drop a pentacle from whatever height is on the 50th percentile, you drop a pentacle from whatever weight on the 50th percentile and drop it downwards. That will be your height age and weight age. So in this case, the boy is 160 centimeters, the weight is 60 kg. So you drop a perpendicular on down like this. You made a pin parental line. So drop a perpendicular here like 50 percentile. So this is your height age, which is 14 years. Now for a weight, you have to drop a perpendicular on the 50 percentile downwards, then the weight. So this boy is weight age is 17 years, the height age is 14 years, actual age is 12 years. So chronological age is 12 years, his height age is 17 years, and his weight age is 17 years, height age is 14 years. So that means he's having, so what is it? So weight age is more than height age, more than 17 years, 14, 12. The child is tall and overweight, but weight being more involved, more maximum. So that's what we did. Then we thought, let's calculate broad BMI. Let's do a BMI chart. And then when we did the formula for BMI is weight in kg and height in meter square. So the weight, we already know this child. So he was, BMI was, if you see the weight of this child was 60 kg and height was 160. So 60 upon height in 1.6 meters into 1.6 meter. So that was coming out to 23.4. So this was there. So there it was a nutritional, obesity was nutritional cause. So if you have a patient whose height is also increasing and weight is also increasing, so it's simple. It is simple non-endocrine problem. So tall and obese is simple non-endocrine. So simple obesity, okay? So that's why you must understand. There's no, pathological causes. It's just that eating. So that's why we did and showed you. Now, if there's another patient who's a girl who's 10 years old, whose height is 110 centimeters, she's short. Can you see that? And whose weight is 41 kgs. So she's short here, but weight is more. So, and to draw again, you draw the, height age and the weight age. You'll find that this is the mid-parental height. She's very short. So the height age is here this time. It's coming out to be 5.5 years. The girl is 10 years. Height age is 5. She's very short. And her weight age is coming out to be 12.5 years. So which is, somewhere here, which you can see here. And so the weight age is 12.5. The height age is 5. But actual she's 10 years. So she's short and fat. So most likely it's an endocrine disease, whether it's hypothyroidism, whether it's GHD, and or likely skeletal dysplasia. So this is and another way of this. So that's why if you use a growth chart, if you use a priority growth chart, you find out whether it is simple or some pathological cause. So this is just now quickly 3, 4 slides of basically on the endocrine part of the causes. One of the causes is when the glucose excess in the body, whether it's iatrogenic, whether it's a Cushing disease or whether Cushing syndrome. So these are some features you will see in this patient. They have a fat round moon face, very typical. Purplish striae are present. Then they have, a fat deposit on the abdomen and on the back of the neck, buffalo hump, very commonly seen. So they have thin extremities. They have in the female, you may get amenorrhea and hirsutism, and you may get bruises or petechia. And because of the successive osteoporosis, increases the factor. So hyperglycemia is there, and then this one. So basically, that's what we want to show some features that can occur in these patients. So that is not there. So now coming on to this is a very interesting case where this is a patient was Cushing syndrome. So Cushing disease is when the pituitary is involved in resulting in injects steroid, known as Cushing disease. When it is non-pituitary from outside, so this patient was given by some doctor was given to use clobestol, was a steroid and applied at least once. So this child was being applied 3 times a day for her, rash. So the napkin rash. So this was applied. So that steroid got absorbed, and resulted in this child being a round mount faces. And you can see a lot of intertrago. And you can see here that all a fat deposit here. And this is it. So this is because of just clobestol application. We have published this case in the literature where a long-term application of steroid can result in Cushing syndrome. So Cushing disease is when the pituitary is involved. We call it as Cushing disease. So the same typical features are there. The features of Cushing syndrome and Cushing all are similar. The only thing is the cause is different. Okay, it is another family of hypothyroidism, another cause of obesity. And you can see here the child is short and obese. And this is another child who is very short and obese. After treatment, this look how smart he's become now. This is another thing which you have. This remember that case I showed you. So Prader-Willi, obesity, too much eating, growth retardation, hypogonadism, mental delay, hypotonic. So it may not be necessarily find all these features in the patient. There may be patients who are having some features, some. So that's why sometimes you only will come to know when you do a genetic test. So this patient are normally having maternal disomy, 15 chromosome 11 deletion is there. So you can see here that this is, very short hands and this thing horse. He has an almond shape, ear, eyes and chubby and, here all you can see on this girl. So very, very obese. So there's another Prader-Willi family. There two are there. So this you can make out the difference. See this in this one, the limbs are okay. Here there are short and stubby hands. Short and stubby hands. Oh, there's another interesting one, Bartle beetle. So basically, you have in these patients, you have involvement of the eyes, you have, besides that, you have you have got multiple fingers. So you have polydactyly. So you can see here 1, 2, 3, 4, 5, 6. Can you see here? Appreciate 1, 2, 3, 4, 5, 6. Here you can also appreciate. There's one here, the 2, 3, 4, 5, 6. So it's a polydactyly. So this family has both the kids with Bartter-Biedl syndrome. So that's why interesting to name this you. So this is also there. So this is a syndromic cause of obesity. Oh, very important. This is just a 3 year or another 3.5 year old child who was having, he had melanocortin receptor mutation, and that's why he got into obesity. So therefore, these rare causes, but these are there. One has to keep in mind. So leptin deficiency, leptin receptor deficiency, mutation of the receptor MC receptor, MC4 mutation, and mutation of PSK. So that pathway I had already shown you from leptin receptor, then to the in the hypothalamus, the arcuate nuclear pattern. So arcuate nuclear, then you had that you had the receptor, and then you had POMC. Then after POMC, you had the disease of MSH, and MSH you had MC orientation. So these were already showed to them. So let's, before you go further, history. History is very important. So take a good history, antenatal history. You're more concerned with gestational diabetes or hypertension and pay growth, because birth weight is very important. Know what happened to the birth weight and how is going to be, was it small or large potato baby. Then plot the anthropometric data on appropriate growth chart. Use the growth chart what to see whether this catch-up growth is there, the smaller babies, very early weight gain, or or weight gain in the puberty or before the puberty start. Family is important. Grandparents, parents, siblings. See the anthropometric obesity tends to run in families. That's very common. So focus on the morbidity related to increased cardiovascular. So there's a morbidity chance. So you feel where patient has got diabetes, dyslipidemia, hypertension, avoid cardiovascular disease. So all this should be there. Okay, you can see for that according to PL. If is a child or the adolescent using any medication, especially glucocorticoids, antipsychotic, psychotropic medicines, to this results in weight gain. You see whether the system, like sleep pattern, snoring is there, more commonly seen in these treatment with obesity. Physical limitation due to orthopedic populations, they may be having blonde disease, they may be having bowing of the tibia. So mood system, focus whether they are having binge eating, whether the bulimia is there, dieting. So in female adolescents, they may have PCOS and other complaints. So talk to them about irregularity of periods and the presence of hyperinsulinemia or hyperandrogenism. So whether that's there. So whether they have any hair on the face, they have hair in the body, and even excessive hair. So that you wish up. Developmental day, the best thing is to see how they're doing in the school. So that'll give an idea. So what a pediatrician or a physician to assess the physical activity? So sedentary behavior, physical behavior. How much hour is spending on television, including videos or movies? That you should understand. Hours spending video games. So whether hand and internet online, hours spent on computer internet-based activities, hours spent talking on telephone or texting, hours spent doing productive activities such as homework, how much time is spending homework on reading and computer-based learning. So these are all sedentary behaviors. So that's why you should know how much is being done. Physical activity behaviors, what is the type, the frequency, duration is doing of structured physical activity. So that means such as sports. So that is structured, organized physical. Then how much he is doing unstructured play. So outside play, routines, activities like walking to school, coming back from school. So these are unstructured. So that's why you have to know the sedentary behavior and physical activity behaviors. Okay. So on these are something very important because it helps to give an idea of what is actually is his lifestyle. Examination, height, weight, PMI, waist circumference, growth charts. This is very important. So then the stigma of syndrome, dysmorphic features. So weight, height, weight, BMI, waist and growth chart. Stigma of dysmorphic features. Tanner stage. Acanthus nigrans. Okay. So Tanner staging is there. Acanthus nigrans is there. Hyperandrogenism, Kishingoid, blood pressure. Okay. Then genovalgum hyperlidosis, skeletal deformities. So this is there. So weight, height, BMI, waist circle, growth chart. You can plot the growth chart. You can see the stigma syndrome, dysmorphic features, Tanner stage, acanthus nigrans, hyperandrogenism, stigmoid features, blood pressure. All these things have to be done. Look for the any orthopedic, genovalgum, any skeletal deformities. Physical examination, obesity assessment, physical and finding and what are possible etiology. So if you find high blood mass in the anthropometric, high body mass index, short stature, likely to be endocrine or genetic condition. If elevated blood pressure, hypertension, if systolic or diastolic prostate more than 95 percentile for age and height on 3 occasions. If the skin acanthitis, commonly seen in obese children, historical acne, polycystic ovarian syndrome, if there is villaceous stria, think of Cushing syndrome. If there is papilledema, cranial nerve palsy in the eyes, pseudotumor cerebral because of the raised tension. And throat, if you find total hypertrophy, obstructive sleep apnea. If you neck, if you goiter, you think of hypothyroidism. Chest, if there's wheezing, this may be because of exercise intolerance. Asthma may explain or contribute exercise intolerance. Abdomen, if there's tenderness or hepatomegaly is there, so it may be a reflux or it may be a. So they don't use it from the term NALFD, non-alveolar. It is called a metabolic dysfunction, steatotic liver disease. So it's like metabolic, they have to change the term, MESLD. So metabolic dysfunction, appreciated cirrhotic liver disease. So that's why they don't use the word non-alcoholic fatty liver disease. Okay, then reproductive Tanner stage, Tanner stage, pre-premature puberty, less than 7 years in white girl and less than 6 years in black girls. So you have that. So if they have a less than 7 year white girl, so this is early puberty or reproductive or a premature puberty. And in boys, less than 9 years. There may be, this is very common, apparent micropenis. So it may be a normal penis which is buried in fat. Undescended testes, with micropenis. So this could be a case of Prader-Willi syndrome. So investigation, fasting insulin or obesity. So screening is done for children over 10 years of age who are obese with or without risk factors. Okay. Obese children 2 to 10 years with risk factors should be investigated. Overweight children older than 10 years and have 2 or more additional risk factors, which include a family history of type 2 diabetes in a first or secondary relative, high risk ethnicity, like Africans and Asians also. Acanthus nigrosus is there, PCOS is there, hypertension, dyslipidemia. Again, MASLD, metabolic dysfunction associated steatotic liver disease. So that's there. In a child, it is for altered glucose metabolism, whose severe obesity, positive family history of type 2 diabetes, or gestational diabetes, presence of acantharin diagrams, history such as a polyuria, polydipsia, a standard GT should be performed. Okay, so it should be done. So maybe picking up a diabetic, otherwise you don't pick when you are fasting. Lipid profile, that means is very commonly seen obese, elevated triglycerides and a lower HDL. So when should you do this? A screening should be done for 2 to 8 years with a BMI greater than 90 percentile. And for older children, like above 8 years, it should be done with BMI is greater than 85 percentile. So that's where this criteria is there. So you can do other tests also for like FABC and iron full blood CBC and iron studies, HbA1c, vitamin D, B12, folate, depending upon what you find. So there may be some endocrine problem that maybe you might need to do vitamin D and maybe magnesium. So additional tests which are based on depending on the disorder, obesity syndrome. If you're expecting Cushing, maybe you might do uniform cortisol. If you're expecting PCOS and androgen can be done. Karyotype or genetic studies can be done. Prader-Willi and Bartleby and all those. So bone age will help you sometimes. PCOS workup depending on the PCOS case. Genetic studies, I already told you, whole exome sequencing, microwave, and sleep studies. So if the patient is a little older and is snoring and is problem, so do a sleep study. So, but not everything for everyone. So just see the patient and decide accordingly what is to be done. So what a pediatrician do, it's a very simple algorithm for the evaluation of each child. So if the BMI is more than 95th percentile, history and physical examination, if the history of obesity is onset at the age of, before by age of 6 months, consider this leptin signal at the pathway which I showed you. Use a medication associated variant after medication like psychotropic or steroid. You change the choice of therapy. Low growth velocity. So rule out hypothyroid growth hormone deficiency. And maybe if there is pseudopeptide hyperthyroid type 1A or Cushing syndrome, you have growth velocity. Increased growth velocity, normal development, no early onset. So unlikely to have a diagnosed etiology. Screen for metabolic complications. That means simple obesity. So there is increased growth velocity, no early onset. So that means you may have metabolic association complications of obesity, which may be hypertension, diabetes. So those simple must be screened for that. If there is history of CNS injury, which may result in neural dysfunction, so hypothalamic obesity is a cause, and you might need to do imaging and test for pituitary function. Other abnormal physical if they development delay, physical finding, small feature, then consider genetic cause like Prader-Willi, Bartle-Biedl, Smith-Magenin syndrome. These are some syndrome which you can have with this patient. What are the complications of obesity? The complication is neurological pseudotumor cervi, raised intention to vomiting, may have sometimes fundus changes, maybe there, may not be there. Psychosocial, poor self-esteem, depression, eating disorders, sleep apnea, sleep apnea, asthma, exercise intolerance, then cardiovascular dyslipidemia, hypertension, chronic inflammation, erectile endothelial dysfunction, gastrointestinal gallstones, and steatohepatitis. Okay, that is a problem thing. Renal glomerular sclerosis, And then musculoskeletal, renal and glomerular sclerosis. So there is a glomerular sclerosis can occur. You can have musculoskeletal, skip capital femoral epiphysis, bone disease, fractures, flat feet, endocrine type 2 diabetes, precocious puberty, polycystic ovary, and hypogonadism. This is what you can find. So what is the treatment? Treatment is lifestyle modification, diet intervention, physical activity, school intervention, family intervention. So all these have to be done together, then only you get some results. So what are extra recommendations to learn? So every child who is obese or this thing must have moderate regular exercise. This is so minimum 20 minutes and at least 60 minutes, 5 days a week. Encourage them to reduce idle time. Tell them to walk to school, come back from school, go upstairs. Don't use a lift. Go the stairs. More walk. Use the stairs. Increase movements during the recess and breaks. Not to sit and keep on chatting with each other. Move around and this thing. Walk and talk. Walk and talk. So what dietary changes? At home, limit fast food, processed food, high fat food. Limit free sugars, drinks, with all those things which are free sugar. Avoid grazing. Keep on eating in between, keep on eating, so avoid grazing. 5 to 7 servings of vegetables and fruits per day. At school, healthy choices. Number of portion to be small. How to see, it's very common. The people go to buffet, they start with sweets and then they think what else to eat, but let's take sweets first. So check correct sequence of items in a buffet. Healthy diet should be 55% carbs, 30% fats, 15% proteins. Avoid fat diets. So is there in the in the child and the adults, is there something called as restriction of the caloric restriction to be done? So there's a question mark on this. So it's better to promote healthy eating versus caloric restriction. So what about the role of special diets? Low carb, high fat, there's a lot of talk. I don't think there is much. High protein, intermittent fasting, we're hearing a lot about it. There is not enough scientific evidence. So family-based dietary intervention works better. So the whole family sits together, eats only that much, 4 point, everybody works together on it, taking less. So the children and adolescents will also have a better. So this is much better family intervention. What are the recommendations for screen time? So this is what is given by the American Association of, here Academy of Pediatrics, and here also in India also happy. Screen time not more than 2 to 3 hours is a risk factor for obesity. Avoid screen before the age of 2 years. Completely banned. Less than 2 hours for after 2 years. It's a very common practice in India. The child will come to you and mother wants to talk to his parent. She'll put the mobile in front of the child and then he'll be busy watching some vague program and then she'll start explaining to you. So it's very, very common, 6 months, 8 months, 1 year children. So avoid screen before 2 years, less than 2 hours after 2 years, non-academic screen time for 1 hour per day, maximum 1 hour per day. Try to supervise the screening and co-view. So watch along with the child, high quality. So and avoid screening, especially during meals. So media-free times with meals. Okay. Who deserve medicine? The next question, pharmacotherapy. Who deserve medicine weight loss? Obesity with failed life. You have done lifestyle management, you have failed yourself. Already have comorbidity, you already have hypertension, you already have dyslipidemia, you already have diabetes. So it's better to go for medicine, weight loss medicine also. So pharmacotherapy injection with a lifestyle. No pharmacotherapy for overweight below 60. So they are just lifestyle and this thing. So there's very nice, this thing, that obesity decision support chart, 5 to 1 0. So guidelines say that eat 5 fruits and vegetables at least 5 or 4 times a day. Limit the screen to 2 hours or less daily. Get 1 hour or more of moderate to vigorous physical exercise every day and 20 minutes of vigorous exercise at least 3 times a week. Zero drink sugar, less sugar. Try water and low fat milk instead of sugar sweetened drinks. All sugar sweetened should be totally stopped. Everything like this should be banned. In fact, all advertisement in the TV should be completely stopped. Coca-Cola and all those other things, these are there, they should be completely stopped from the advertising. So pharmacotherapy is helpful when there's insulin resistance. You can use metformin. Hirsutism, you have a drug which can use for that. Hirsutism, you can use Aldacton or even locally applicate something. Dyslipidemia, you can use some drugs like statins. Hypertension, you can use some drugs. And no response to physical exercise and dieting. So these are useful when you have already done physical exercise and dieting is not responded, go for pharmacotherapy. So for teens, fat pills for teens, Orlistat Orlistat is approved for children. Orlistat is approved for children greater than 2 years, 12 years, sorry. The other drugs are there. So metformin is already being used a lot in children who have high insulin resistance. Celistat is also a drug which is being used. Celistat is basically the only advantage, it does not cause steatosis. So there is no fat leakage of fat being passed in the stool, like which happens with Orlistat. Liraglutide already approved for adolescents, above 12 years, some people say 13 years, but FDA also approved. Semaglutide also coming up, gradually approved for adolescents. And, there is oral preparation, there's injectable preparation, and even now dulaglutide also coming up that can be used in the adolescent population. So we have also done studies, we have published also where we have used liraglutide in our population adolescents, and we have got very good results. So other medicine in which is commonly used in adults, leucosarin, fentotopiramate, nitroxabuprine, not used much in the pediatric and adolescent group. So what are off-label medicines for pediatric obesity? Increasing the one which increase metabolic control, the other which is centrally acting analgesic. So metformin is an unlicensed use, but very commonly used. Not much change in the weight, but it does help in insulin resistance. Then growth hormone, very little effect. Then there is a drug called octreotide. This is being used in pediatric hypothalamic obesity. So SGLT inhibitors not approved for use less than 18, but recently, I think just 4 or 5 days back, the FDA has approved dapagliflozin for adolescents with type 2 diabetes. Centrally acting antihypertensive, GLP-1 and analogs, liraglutide, I already told you that's working. So it's basically trying to decrease satiety. Fentanyl are not approved for pediatrics. Dulaglutide already told in adolescents. Semaglutide is non-adults and adolescents also started working. This is a drug which I was telling. Sitagliptin. It is coming. It's basically agonist peptide drug and can be used above the 6 years for monogenic obesity. So it is really helping patients with PMS receptor deficiency, PM3/4 receptor deficiency. It is also helping in PMC, promomelanocortin, leptin-4 receptor deficiency. So all these it is helping. So serentomide and it's available imricively, similar to imicry. So this is basically it's a very helpful drug. So you can use. So what is recommended weight loss? When you're on treatment, how do you manage? So the recommended rates are overweight who do not have a risk, weight maintenance or weight velocity should be maintained. That's all. With risk, who have risk, that means they have comorbid condition, hypertension, dyslipidemia, diabetes, other things that they're PCOS. So they must lose not more than 0.9 kg per week. So if there's obesity, 2 to 11 years obesity, weight maintenance, weight loss not more than 0.45 kg, 450 grams per month. Okay. 12 to 18 years, weight loss not more than 900 grams per week. Targeting is basically 85 percentile. So 12 to 18 idea is when they come to 85 percentile, then we just try to stop the drugs. Who does a pediatric surgery? That's the next question. So we talked about lifestyle, we talked about exercise, we talked about screen time, we talked about drugs, we talked not deserve that. So last option, it's very helpful in morbid obesity. So BMI is 35, BMI is 40. The technique is important as the children have longer. So these children have like we used to do a surgery at 13 or 40, which is approved now by FDA. They say above 13 you should. You have to be very careful. This child who's surgery is a long life ahead. So patient will need lifelong medical and nutrition surveillance. So you have to be very careful. So child should have attained Tanner stage 4 to 5. That means he's near final adult height before ever thinking of bariatric surgery. The child should have BMI more than 40 kg or BMI more than 35 with comorbidities, severe comorbidities, not just severe comorbidities. So severe comorbidity and severe obesity and comorbidity, but despite good lifestyle, intervention with or without a trial are found for at least 6 months. So it persists despite good lifestyle, intervention with or without trial found for at least 6 months. So patients should demonstrate the ability to adhere to the principles of healthy dietary and activity habits. So that's why. So we be sure that the patient has taken the, your whatever advice you give regarding the diet, where the exercise, he has followed those and then we should take a decision of this. So various types of bariatric surgery, there's malodural ileal bypass, there is restrictive laparoscopy just for gastric banding, then there's a combination Roux and Y gastric bypass, which is causing both malabsorption as well as it. This is the most commonly performed bariatric surgery now these days. I do not like by gastric bypass. So now this is as far as now what is the most important? The prevention. The prevention of obesity or metabolism in children, or due to the fact that therapeutic approaches are only show moderate effects on obesity and death. So because they're not, because long term you don't know what's happening with these kids who are getting surgery at 13 years or who are getting this drug. So prevention is very important. Prevention should be the primary goal and includes both behavioral and community-based approaches. So WHO, they have, they come out with a suggestion that there's 6 key points. Promotion of healthy food, promotion of physical activity, focus on pre-conception and pregnancy care. During in pregnancy, start teaching all these things about care. Starting diet, physicality in early childhood, and special care of health, nutrition, and physicality for school-age children. Okay, so nutrition and physicality, perform a proper weight management. Additional restriction of the advertisement of healthy foods to children. So stop advertisement healthy food to children, which is very common. Coca-Cola, Pepsi, then other things are there. So you avoid that, should be completely stopped. Some of them is stopped already. So improving the school meals. So development of binding quality standards for catering in kindergarten and school. So there should be a standard being okay, this is only what you're allowed to serve, this is what you can give, this one. So all junks to be avoided. JUCN, so junks to be avoided. So implementation of sugar or fat tax to reduce consumption of unhealthy foods. Okay, increase in daily physical activity by offering more physical sports in school and getting is already becoming less. So in the past, people used to have a lot of activity in school. Now everybody says there's only once or twice a week. So that should be increased. So prevention, government policies, taxing sugar, sweetened beverages, increasing value of playgrounds and sidewalks, schools stopping fast food service, increasing playtime, healthy school meal nutrition, family meal time, smaller portions, low glycemic index foods, reduce electronic play activity, decrease screen time, electronic play. So in summarize, BMI charts to diagnose and track obesity, look at the underlying causes. That's just not diet and exercise. Investigate for the consequences and not just the most obese. You might find some even smaller, lesser obese not having problems. Think carefully about investigation and interview results in setting of age, sex, and pubertal stage, for especially for incidence and type 2 diabetes. So you have to start thinking in those adolescents where you need to test for age. Small efforts at a young age can have a large effects on BMI and therefore long-term health. Early childhood, whatever childhood obesity leads to adult obesity. It's a very common saying. The child obesity you are, what was your like, what was your your adult patient Vishka, first thing you ask, what was your weight in childhood? What was your weight at the time you were 10? So childhood obesity leads to adult obesity. Very common. So that's why. So thank you all for listening and your patience. Let's all work together in solving this epidemic of ABCD, adiposity-based chronic disease. Thank you very much.
Thank you so much, sir, for taking out your valuable time and sharing your knowledge on this topic, sir. I definitely think this session knowledge will help all the participants who have joined this session. Sir, we have received some from the participant. If you allow, with all your permission, shall we take these questions?
Yeah, take the questions.
The first question is from Dr. Singhania, and he's asking, what are the biggest challenges you face in treating childhood and adolescent obesity, and how do you overcome them, sir? What's your point of view on this?
So the basic most common challenges is trying to convince them to follow your diet patterns. So that's why you have to you have to be very slow in explaining to them. Then you have to tell them about the advantage of doing it. The most important thing is that when the child start listening to when you tell him you get nice dresses. Girls go to you tell them you get nice dresses, you look more beautiful. Everybody will say you're a smart girl. You say so they start following and start doing it. And for boys, you tell them you look more stronger, you look more healthier, you can have more muscle mass, you will not have that much fatty tissue. The girl will also look at you properly. So, you have to convince them by this method. Normally, it's just telling, you stop eating this, stop doing that. They don't get convinced. They do it and then many times they don't turn back and many times they will not, कि sir, वो doctor तो यही बोलेगा, ये मत खाओ, no use. So these are the biggest challenge and that's how you should overcome this challenge by the methods that I told you. So be calm, explain to them slowly, and whatever you tell them, give the reason with it. Why I'm stopping mutton because of this thing. Why I'm stopping paneer because of this thing. So when you tell them that, and you have to show them your physical Appearance will become much better, everything, but then they start following this.
Thank you so much, sir, for sharing your insight on this question. I hope that Dr. Singhania has received his answer. Moving forward, another question from Dr. Akash, and he is asking, what strategies do you use to manage the stigma and potential bullying that obese children and adolescents might face?
So I didn't get the full question. What is it?
Let me repeat the question. The question is, what strategies do you use
A
to manage the
strategy.
stigma, yeah, and potential bullying?
Strategy, you see, as far as it's a very common stigma, childhood bullying, a childhood, that we don't want to play with you, you're fat. No, you cannot play with us in basketball because you won't be able to throw the ball. You cannot play tennis with us because you won't be able to hit the ball. It's very common, this thing. And many kids come with this problem and they say that I don't want to go to school because I'm bullied around with all the kids or my friends, I think. So I think, this stigma has to be told to them that, that's why when they come, we always tell them that, see, you may be being be troubled by your friend or maybe by your relative or whatever. So we have to tell the family at least not to do all this. Second is that, you have to explain to them and reinforce on them that by losing this weight, all this will finish off. So that means you'll be able to go to school, people like you, people will pay you will play more game. So in fact, by this way, they start accepting the fact that it's good if I lose weight and I'll get more, people appreciate me, people like me, people let me play game, people not bully me. So they're there. But people who like kids, there are many kids who don't listen at all, and then they keep on having. Then they miss school and they miss their, they land up to have other problems. So these are the kids may have maybe called social problem later in life also. So I think this is very important that you try to talk to them, try to explain to them, and try to convince them that once they get the weight loss, they're definitely going to not be bullied or not do it. Because it's very common, this thing. Whoever asks this question is right. It's very common here. And that motu, somebody say motu, 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 somebody say, hey, shotu, hey, boy, ball utha ke dekh. Oh, you can't even bend. So these type of things come up. So I think that's the only way to, get rid of it. I mean, solve this problem.
Thank you so much, sir, for sharing your insight once again on this question. We will be taking one last question from Dr. Shruti, and she's asking, like, what are the primary factors contributing to childhood and adolescent obesity in your patient population, sir? Could you please show some light on this?
Nutrition. जंक फूड खाया खाना खाया जिनको 3 चपाती खाया 6 चपाती खाया खाना अच्छा बना 7 चपाती खा लिया eating more than what is required. The commonest cause is not pathological. The commonest cause is simple obesity. So all these simple obesities, they keep on eating, and most of them are tall with overweight. So these are very typical. When you see them, you know that is simple. So these are commonest cause. I being an endocrinologist, I get a lot of other cases also, but the calmness is simple. So you have to just reinforce on them about the diet part. You have to force them on physical activity because they don't want to any activity. The parents come के तो पानी नहीं पीते पानी भी हमें कहता है नौकरों कहता है खुद आके तुम पानी दे के दो. He wants to do every sitting in the bed. He wants to eat on the bed. He wants to sleep on the bed only, and he wants to eat, study on the bed. He will not go to table to sit and study also. So these are very common thing you find. The calmness is simple obesity. So that's why you have to start from beginning, keep on explaining to them, reinforce them every visit, call them every visit for 1 month and reinforce. And when they become little, loss of weight is 1 kg, 2 kg, give them a gift, give them a reward, give them something. Oh, you've done well. Shake hands with them. Maybe you might even hug them. So they feel very much, oh, you're liking them. I think this is there, but this is the way to go forward. But the calmness which I am feeling is a simple basic nutritional basic.
Thank you so much, sir, for answering all the questions, sir. I hope you have done justice to topic. As do we have further questions, sir. Sir, as we don't have any more questions, sir. With all your permission, shall we conclude this session for today?
Yeah. I think we can conclude. Thank you very much. We've just on
Welcome,
time
sir.
at 4 o'clock. So
Yes, sir.
yeah.
Yes, sir. And we would like to see you in future also with new topics, sir. Till then, take care of yourself. Have a great day, sir. We are closing.
Thank you. Thanks a lot. Thank you.
Welcome.